Some patients lose function of their endothelium, the corneal endothelium. And what we're going to see now is a Descemet stripping only, otherwise known as DSO or DWEC, Descemetorexis without endothelial keratoplasty. That's what we want to review.
And so patients with Fuchs, for treatments, there's two options. All involve removal of the diseased endothelium that can cause glare and swelling. But if the periphery of the patient's cells are still adequate, they can be used to fill in that gap or the defect that will be created here in a moment.
I think that's a key because you want to measure central endothelial density, but also peripheral density. And as long as the peripheral is strong enough, like we just heard, then it can migrate in towards the center. And that's what we're relying on for this type of surgery.
And it's fairly new, so we don't know the long-term outcomes, but it turns out that less than 5 millimeters centrally can be removed safely with a pretty fast recovery. As you saw, this was 3.5. This is still adequate in this size, and this is about the same. Little oval. I tend to not be very picky if it's round or oval, as long as I have a nice diameter that can still remove the glare portion or the symptoms causing portion.
And I think off the bat, I'm thinking of some advantages because we're going to look at a surgery where endothelium is removed and nothing is put back in its place. So on one hand, I'm saying, well, now there's nothing that can reject or really have a problem because you're not putting any new foreign tissue in there. And secondly, some parts of the world just don't have access to a lot of cornea banks and a lot of corneal tissue.
Correct. So this is, and also as far as invasiveness, these are two small, maybe 1.2 millimeter incisions, so it's much less invasive. And also the manipulation is done in a closed space on the viscoelastic. With any of the endothelial keratoplasty, usually there's a change in pressure, there's lots of manipulation. This is manipulation, but very delicate. The majority of the time you'll see I'll just spend on slowly and carefully creating a little tear on the endothelium and then moving it around. And the tissue that I'm working with here is about 50 to 100 microns. It's very, very, very thin.
Well, that care is so essential too, because I think when we think about the stroma, if there's any defect in the actual corneal stroma, now we're leading to something that's going to cause a scar, a permanent scar for the patient.
Correct. So I only want to go through the endothelium, not through the stroma. So I just apply enough pressure to go through the endothelium, but not cause any fibers or tears to the stroma. Hence this care and time spent on this.
I get questions sometimes from students with something like a Descemet stripping only, and they say, well, Descemet, isn't that part of endothelium? And yes, Descemet's layer is the basement membrane of endothelium. So you take one, you take them both.
Correct. So we focus on Descemet because that's the part I actually affect and treat. But yes, we are taking endothelium with us at the same time, just like you said, because it rests on top. And here it's literally peeled off slowly. This is when I'm happier because I can just remove this and not as concerned. It's almost as similar to a rexis in the sense that it's peeled around and removed in one piece. And you can see this is less clear than normal, like all these little dots, and then comparing it to this view, which is much better than it was before. And so if you can obviously scroll back and like watch the video initially to now, and you'll see that this is more clarity than we had in the beginning.
Just the concept of this surgery is so intriguing to me because I think about driving a beat up car and somebody might come to me and say, look, you know, you're better off with no car at all and riding your bike to work. And we're looking at an eye and saying, look, you're better off with no central endothelial cells. And that's really what we're saying, because remember, we're waiting for those peripheral cells to migrate in.
Yes, so you're better off with no endothelium for now, being replaced by your own. We're not saying no endothelium. And again, this is the key. It's a very small area. I would never do this in a large one, because then the recovery time would be too long, and also the outcomes wouldn't be as good. This recovery time is usually within a month, and it's an improvement of vision, and clarity is about 3 months. And this little forceps is just used to remove any little tags that might be still left on the endothelium. So as you can see, it's not a perfectly round, but more of a cloverleaf appearance almost. And I want to show you have nice clean edges that then allow the endothelium to go over very easily.
Would a scallop, is a scalloped edge a fair word for that? Yes. I kind of like thinking about that kind of scalloped edge around. That's what we see. And it's not uncommon, like we talk about. This is going to take a lot longer to recover visually compared to something like a DMEC or a DSEC. And that patient, we were talking about a month or two of central corneal edema, but we'll see that size get smaller and smaller as those cells are migrating in.
So initially, the vision is significantly worse, much worse, in fact. Most commonly count fingers, maybe 2,400. And here I'm just pointing out the area that is clearer than in any other transplant, and it tends to stay poor. So a patient doesn't have patience, this would not be a good procedure for them.
So find a patient's patient. Is there anything else that can help speed up the recovery after something like a DSO?
Studies are now looking at certain kinds of ROCK inhibitors, ROC inhibitors, that may help growing of the endothelium. There's one out of Japan, Glanatech, that has maybe some promise, but it's not FDA approved in the United States.